I'm very excited about today's guest, obstetrician gynecologist Dr. Colin Birch. Although our paths rarely cross in person, I've known Dr. Birch for several years as a physician, as an expert witness, as a fellow conference attendee and speaker. Both of us are longtime residents and have worked with the Alberta Health Services in the area of obstetrics and gynecology for several years. We were once both experts in the same medical malpractice trial, he as the physician expert, me as the nursing expert. He's performed surgery on one of my many sisters a few years ago. But the reason I'm super excited about having him here is he brings such a fresh perspective to this topic of medical malpractice, very well-rounded on the topic. He's a practitioner of medicine, a medical legal expert, and he's also been named as a defendant in a lawsuit. He's been a doctor, he's been a patient. He's worked in the obstetrics and gynecology area for more than 30 years, currently practicing at the Foothills Medical Center and as a visiting OBGYN in Canmore, Alberta. Prior to moving to Calgary, he served as the regional chief of obstetrics in Timmins, Ontario. He was recruited to Calgary for his skills in endoscopic surgery in 2000 before returning back to the UK, and you'll figure out where he's from as soon as you hear him talk with that lovely accent, for a fellowship in pelvic reconstructive surgery at St. George's Hospital. Dr. Birch has served as the site chief for the Department of OBGYN at Foothills Hospital from 2005 to 2015. He was the regional head of gynecology for the Calgary Health Region from 2007 to 10, president of the Western Society of Pelvic Medicine from 2013 to 2018, and he is currently has an expanded role as the head of OBGYN at the University of Calgary and Alberta Health Services Calgary Zone. He served as an examiner for the Royal College of Obstetrics and Gynecology of Canada and currently chairs our committee providing opinions and analysis on legal matters. His professional interests include new techniques in uterine prolapse surgery or pelvic prolapse surgery, childbirth injury involving the pelvic floor, and abnormal placentation. He's presented more than 100 times at national and international conferences and meetings. He was born in England, graduated from medical school in Newcastle upon Tyne, completed his surgical residency in London, and then obstetrics and gynecology residency in St. John's, Newfoundland. So welcome, Colin. I mean, what a wealth of knowledge and experience you're bringing to the table today. It's great to see you again.
Well, Chris, thank you very much for inviting me to do this. I'm quite excited to do it. Thank you.
I'm excited too. You know, often when I email you or when I was putting together questions for this podcast notes, your last name, Birch, autocorrects itself to birth. Does that happen to you too?
Actually, yes, quite frequently. I've been called Dr. Birth on a number of occasions, which I think if I was Dr. Phil or Dr. Oz, I'd actually be flattered. But yes, it's quite often that mail comes with Dr. Birth on it, which is, I'm not sure that's autocorrect or people just assume because of what I do, Chris.
Well, in my world, it autocorrects, and I always find it a little serendipitous, and I will often want to leave it alone, but I know your real name, so I always fix it. I just want to, we're going to talk about a lot of different things today, but I just want to let everybody know that you and I have attempted to plan this recording of this podcast more than once over the last several months. In fact, most recently, we were scheduled to record yesterday afternoon. But we had to reschedule it because of an emergency COVID meeting that was called, and you, as of course, a leader in the field of obstetrics and gynecology, had to take part. It's early 2021, and as much as upsetting as it is and prolonged in the seemingly never-ending pandemic, COVID-19 is still very much a thing. Before we get ripping into the questions, talk to us a little bit about how things are going in the world of OBGYN in the midst of a pandemic.
Well, I think it's been very challenging times, Chris, and it's challenging in so many different ways. The societal challenges that everybody's been experiencing, but obstetrics specifically has had its challenges. And the first challenge has been basically care of the maternity patient. And the reason for that, I say that, is because it's generally felt that the hospital is dare I say, a hostile place to go to from an infective point of view. And we've seen this in other specialties, but also there's been a move in this in obstetrics as well, where women really are worried, concerned with going to a hospital to have their baby because they feel that the hospital is an infective centre, as it were, and they're putting themselves at risk of doing that. And I think, though, yes, patients who have COVID obviously are housed in hospitals, the actual processes that are now being put in place, which have taken a long time, I hasten to add, because there's so many considerations with COVID, so many considerations with mothers, so many considerations with babies, that making sure that we can allow the birth experience to be as it always should be, but at the same time keeping one safe from an infective point of view. The second, issue, of course, has been the fact that with pregnancy now has become an independent risk factor for severity of disease in COVID. And the issue, of course, has been manyfold. Initially, it was felt, and the initial data really suggested that COVID wasn't particularly that much of an issue from a pregnant patient population. And although people tried to draw analogies with H1N1, what we've found is that there are increased, first of all, when pregnant patients get ill, unfortunately, though they don't get ill any more frequently than someone who's age matched, but when they actually get ill, there's any greater risk of severe disease, ICU, ventilation, unfortunately. Some people say mortality as well, but the statistics are so small on that, it's hard to draw any conclusions. But certainly, the other issue, of course, is what's developing is there are issues associated with COVID, people who've been COVID infected during pregnancy. Risk of preterm labor is increased. The risk of abnormalities during labor is increased, certainly fetal heart rate abnormalities. And this is where the disparity has come, because there has been somewhat of a move towards home birth to avoid the hospital. However, it's recognized that there's been increased fetal heart rate abnormalities during labor, which would describe that the patient needs to be in hospital to be able to have those addressed. So it's a bit of that's been a very interesting conversation as well. And the other issue, of course, for us, and thankfully we haven't seen it that frequently, we've been very fortunate in that regard, even though Alberta, for its population, has the highest number of COVID positive pregnant patients in Canada. In fact, well in advance of anybody else, unfortunately, is that when pregnant patients get sick, they can get sick very quickly. And that's been a maternity issue, obviously, when it comes to delivery with a decompensating patient, where the patient delivers, how they deliver safely. And the third issue, without belaboring this point, is vaccination. And that's a huge topic. I mean, not a huge topic societal, but also a huge topic from a point of view of the pregnant patient, because there's no data from the studies regarding the use of vaccination in pregnancy, and therefore there's always that safety issue. Though we believe, and I likewise, again, it's a risk benefit, and I think it's an important conversation with maternity patients, that it is because of the independent risk factor for severity of disease that vaccination is advised. I mean, we can't say recommended because we don't really have the data to say recommended, but certainly advised in pregnancy, just like we advise currently for influenza vaccine, specifically against H1N1, which again was a severe disease in pregnancy. So as you can see, there's been quite a number of topics in pregnancy related to COVID in the past year. I hate to say it's the last year already.
Well, that is a fascinating breakdown that you've just given us there, and you've certainly introduced some new subjects that I wasn't even aware of, and I'm sure the science and the data on this is just changing almost on a daily basis. It must be a challenge for you to keep up with. I'd love to talk about many things there, but we have lots to talk about today. But I do want to ask you, how and why is it that, or do you know why Alberta is leading the way in pregnant patients who are testing COVID positive? Can you account for that?
We're not sure, to be honest. We have two of our members who are on the Can COVID project, which is a project across Canada led by Dr. Money in BC, which is looking at outcomes from a pregnancy point of view. And really, it's probably more at the statistical base at this point in time, looking at how many cases, severity of cases, and the like, and the outcomes, obviously. But yet, there's yet to sort of really be able to identify why specifically Alberta seems to be have led the way when it comes to COVID positivity. What it hasn't equated to, thank goodness, is we haven't seen a lot of severity of disease. So it's basically had increased numbers, but we haven't seen the increased severity that certainly there's been seen in other places. So we've seen, for the most part, fairly mild disease.
And how about outcomes, maternal or fetal outcomes? Any association with COVID and poor outcomes?
Again, really, there's been a lot of talk regarding COVID and associating. And really, the poor outcome probably is associated. There is going to be a poor outcome right now. We will be associated either with preterm labor and the consequences of preterm labor, or the consequences of abnormal fetal heart rate. And as you know, so-called fetal distress, we there call it that in parentheses. So that's more the outcome. There's been no congenital abnormalities that have been associated specifically with exposure in the first trimester, for instance, with the data we have at this point in time. And it's an ever-evolving field. There are lots of people, dare I say, who put themselves forward as experts in this. I don't think in a disease process that's been really here for less than a year, there are that many experts. There's lots of opinion right now. And I think data will evolve, and we'll look back like we did with H1N1 and realize, what the effects of it were. But on first blush, we don't seem to be seeing much from the point of view of severity of disease in Alberta comparative to the number of patients we're having.
Well, that's good. And I just want to thank you for the work that you're doing in that field. I have no doubt that it's added a huge amount of challenge to your workload. And I know I can see you nodding your head. I mean, so thank you so much for the work that you're doing and the challenges that you're facing. It'll be so fascinating a year or two from now, when this is all behind us, or hopefully all behind us, to have a look at how this affected. But I guess this research might go on for a decade or two, or even a generation or two, to sort out all the details of how this has affected so many lives.
I believe it will. And it's something, and the thing I think is interesting about this, and I think infectious disease and obstetrics is an evolving specialty in itself. And I firmly believe that if we think this is the last viral epidemic / pandemic we're going to see, and it's because of a whole number of different reasons why, and people will extrapolate, is it climate, whatever. This is really it's really kicking the tires of our response. And I think what's very interesting, as a little aside, when we came to write our strategic plan to deal with COVID obstetrically, we couldn't find the plan we had for H1N1, which isn't that long ago. So it's interesting how quick we forget. But I think COVID is really just kicking the tires of our response. And I think it's going to be prudent for us to have, if we call it disaster response, ready, because this is not the last virus that's going to roll around for my lifetime, for certain. No,
that's for sure. Those of us who've been in healthcare a while have seen other pandemics come through. I remember I was the home IV nurse during the AIDS epidemic, which was, such a huge and scary risk. And not that makes this seem any less scary, because it's certainly broader and affects a much wider population. But I feel like this isn't the end of it. This will come around again. But I'm also, other than the fact that you can't find, that you can't locate your, most recent disaster plan, I'm also kind of reassured that we survive and we forget and life goes on, and this will be in the rearview mirror one day. So grateful for that.
It will, but I think our disaster plan will not be in some cupboard with dust on it somewhere. It'll be on every computer that we have.
I hope so. I hope so. There's your plan B after you've stopped doing your clinical work. You can be the OBGYN disaster planner.
Yeah.
So let's back up a little bit, because I would love to talk about this forever, but this isn't a podcast about COVID. It's a podcast about medical malpractice, and you have a wealth of knowledge and information to offer us. So let's talk, first of all, just a little bit about you and your decision to become a doctor. What led you to specialize in the area of OBGYN and pelvic medicine? And then you're focusing your specialty on the area of obstetrics and pelvic medicine. I'm just fascinated to hear where you're at.
How did I get into medicine? I fell into medicine because of just as a very aside, in the English educational system, schools were rated regard people who went to medicine, law, Cambridge and Oxford. So I had desires to do other things, but was actually streamed into doing medicine. So, and then I went to medical school, and within 6 months was totally hooked, and I couldn't think of, and it sounds very mustard and apple pie, anything I would prefer to do more. And I'd always thought, and we say this, and it sounds almost pageantry, that I wanted to help people do decent things in the world, change things in the world. So, but it's actually true. I just wanted to make a change and help other people, because in England, medicine was, you went into it basically to help people. It was, there was not, and have some stature, undoubtedly. So I went to medicine. I then did a surgical residency in London, and medicine in England was an impasse. And dare I say it, with accents like mine, London was not oftentimes a very open place to get employed. So a job came available in Canada, and at that point in time, it was obstetrics and gynecology. And I'd actually always enjoyed obstetrics and gynecology. And in England, you had to do some part of a surgical residency to get into obstetrics and gynecology. Then I practiced in general practice once I qualified for about 10 years, and realized that I had interest in certain aspects of the specialty, high-risk obstetrics, but pelvic floor specifically, which is birth-related injury, essentially, and endoscopic surgery. So I did a kind of quasi-fellowship in endoscopic surgery. Then I went back and did the fellowship in London, which was a couple of years. And that's sort of how it's directed my career. And so my career has gone from being a very general gynecologist and obstetrician to doing the higher risk obstetrics, endoscopic work, and pelvic floor. So it's been an interesting journey, because each change has sort of perhaps specialized me a little more each time I've gone along. And so here I am now with that sort of makeup to my working week or day.
Well, again, thank you on behalf of all of us women who've had 1, 2, or 3 babies, and deal with the obstetrical experience, and then the fallout from that, the pelvic floor issues that go with that, and there are many women. Thank you for the work that you're doing so much. So, let's focus a little bit more then on your work as an expert witness. But let's start by asking you, in your career, have you ever been named in a lawsuit?
I have. And to expand on that, I think doing obstetrics, as we've already spoken about, being named in a lawsuit is almost an occupational hazard. I think medicine is in general, but obstetrics specifically. And I think because of its nature, if you do enough obstetrics, regardless of how good we think we are, it's going to happen, because with obstetrics especially, and I think labor and delivery even more so, there is an X factor in managing, as you know, patients in labor, because it's a very dynamic environment whereby there is, oftentimes you can question decisions you make, and if the decision you make ends up with a poor outcome, it leads to a lawsuit more often than not, unfortunately.
Yeah, and I appreciate that you said if you work in obstetrics long enough, because I know I've mentioned this on the podcast before, but I've been named once in my career in a lawsuit, and I have this little letter tucked in a drawer in my dresser for another one where there was a very bad outcome, and I just happened to be present, and so I'm just sort of semi-waiting for that one to show up. Talk to us a little bit about that experience from your perspective as a hardworking, practicing OB when you get named in a lawsuit. Talk about the reality of that.
Yeah, it's interesting. It doesn't matter how long you've been in the specialty, how confident you feel about your skills. The day that someone presents you with that paper is not a red letter day, I think it's safe to say. And I mean, and I think we go through a stage of emotions, and I can only talk for myself. I think everybody else does the same. The first is kind of grief, because the reason there's been a lawsuit is because there's been a poor outcome. Now, when you're first served, it's just a name. So unless it's been something that's very recent, which oftentimes it's not. Oftentimes there's quite some time between the actual instance of the case and actually when you get the lawsuit served. The first is absolute grief that that perhaps something you've done has resulted in some poor outcome from them. Then you go through the stage of anger that, here I am, I've done all this training, I try my very best, I go to work every day trying to do my very best for everybody and every patient that I see and try and be decent to them, and someone's going to sue me over that. And then when you got over that, then you get to the self-doubt, because there's that time frame between being served and being able to access the chart to remind you what actually happened and what was the case, where everybody will go through some element of self-doubt. Well, what if? Is there something to answer for it, or am I just somebody, as you say, on the periphery who just happened to be walking through labor and delivery that day, and I actually ordered something on a patient, and it just happens that I'm and you don't know that to start off with, because you're just named, and there's a list, the catalog of names on this when you're served, and you really, there's that period of self-doubt and worry that, oh my goodness, how involved was I? Unless you remember them. And as obstetricians, we do remember the cases where the outcome wasn't what we liked it to have been. I think we carry that in our brain. We have a certain part of our brain that perhaps other people don't have, where we carry the weight of these poor outcomes when they happen, more obstetric than gynecologically, but still. And then there's the realization you've got to contact CMPA, and you've got to lay yourself bare as to what you interpret. And then finally you read the chart that you have documented on. And I think we all feel that we document well, but then we go back and look at it again in the cold light of day and think, well, I could have documented this better or something. So you go through a whole rash of emotions once you're served. Well, I do, and I've only been served twice, and it's never got beyond discovery, but still there's a whole rash of emotions you have.
Yeah, it's interesting, because what you're saying there is very much in keeping what I've heard from other doctors. And we had a New York internist on the podcast last year, Dr. Danielle Ofri is her name, and she's described a very, very similar experience to yours.
Yeah.
And she really talked about, she called it shame. Is, at some point you just question your worth as a physician and why you ever even got into medicine. Yeah. That really shameful feeling. So thank you for being as open and honest about that as you just were, because I don't think, I would say that's been my experience as well. There's so much questioning that goes on. And the grief is real, isn't it, when there's been a bad outcome, especially with a mother and a newborn baby.
With obstetrics especially, because we have two patients, not one.
Right.
And so, unlike other specialties whereby there's one patient, so if something happens, it's one. With ourselves, it can be one, the other, or both patients who end up with a poor outcome. So there's that ongoing jeopardy if you do obstetrics especially.
Sure, sure. And I guess, it's important to always remember that not every outcome is good and not every bad outcome is anybody's fault. I know the one case that I'm always waiting to be named in, this patient came to the door and the baby was compromised before she arrived, but still there's a bad outcome. And the reality is they've got a child to raise for the rest of their life. And it wouldn't be unreasonable or surprising if this shows up one day. So you then talk to me about then how, because you also do work as an expert witness and you do medical legal reviews for, I believe, the SOGC, or you're on subcommittee there. How did your experience of being named as a defendant in a lawsuit translate then into expert witness work, and how do those two play off of each other or affect each other?
That's a very interesting question, which I've never actually thought of an answer to, so I'll think of it now. What it makes you do, I do expert opinion for both plaintiff and for physician. And what it makes you do, when you first giving opinions, which I've done now for probably 25 years, when you're young, you tend to be a bit more judgmental. And there's a number of factors behind that. But when you get older and more experienced and have actually a lawsuit sort of started against you, and I saw the opinion that was given regarding my care, I thought, wow, that's really judgmental. And it was almost, I would say, advocacy, as opposed to a basic review of the factual information you have in front of you. So how it affected me, I think, to be honest, would be that if I give a medical legal opinion now, it's based on fact and there's no advocacy involved. So what I mean by that is, and I think that's where quite a lot of expert witnesses fall into, is that they seem that they have been taken on by, and let me put it this way, sides, that they feel they need to necessarily advocate as opposed to actually look at the data and look at the case openly and say, with the facts, this is what a gynecologist or obstetrician would be expected to do. And there's I think a huge difference. And to start off with, I must be honest, I made opinions that were quite judgmental. And when I got the first suit against me, and I said it just got as far as opinions, I realized that really it's not my job to be judgmental. It's my job to be able to give you a very honest, straightforward opinion regarding the facts are put in front of me and what will be expected of a trained gynecologist / obstetrician in Canada, were they presented with those same situations. And I think that's how it affected me.
Well, that's interesting. And I think it seems like that experience turned you into probably a stellar expert, because as you know, I've done quite a bit of expert work myself. And I would say my journey was the same. It's easy to be nitpicky and find error with 1,000 different things. But even when it's not against my practice or I receive a rebuttal to my opinion, and someone is very, very nitpicky towards you and your knowledge and your education, they'll attack almost anything. It does soften the edges a little bit and, force you to become unbiased and dispassionate and just take a step back and look at the facts. So that's really, I'm sure that makes you a very valuable expert in your own right.
Well, I think it's, sorry, Pam.
No, go ahead. Go ahead.
Well, I think that's the way it should be as well. And I think, and this is just a personal opinion now, I think when there are very judgmental, or you say nitpicky opinions, those are the issues oftentimes lawyers will pick up on, because there is a disparity by virtue of the fact that the way that lawyers look at this and the way that physicians look at this is slightly different. And I always say to people that it's very easy for me to give an opinion, a dispassionate opinion, because I have hours, days, weeks to look at the information, go back over and back and forth over it. Yet, as an expert, we should put ourselves in the position of the person who's there, where, especially in obstetrics, as you well know, decisions are contemporaneous. They have to be made in seconds, minutes, and you haven't got the luxury of saying, okay, let's sit back and look at this and ask somebody else's opinion. It doesn't happen that way, and we're in a situation which is so dynamic. And I always sit there when I'm doing an opinion and I think, well, okay, put yourself in this opinion, in this situation, and give you a certain period of time to make a judgment, rather than having the advantage of looking at this for hours. And yes, if I look at something for hours, I could probably find fault with most everything I do, if I'm being perfectly frank. Most of it's trivial and inconsequential. But as an expert, you have that. And the legal profession looks at that as well. They look at it dispassionately, but with a long period of time to look at a decision that otherwise may have taken 2 minutes. So I always think that's very interesting, and I always try and look at it as an expert and put myself in that position. And frankly, having been in obstetrics for 30 years, I think I've probably been in most of those positions at some point in time.
I'm sure you have. So do you give yourself 2 minutes to provide opinion, or no?
Well, no, I give myself 2 minutes to just look at it quickly and say what you do. Though obviously when you get asked to give an opinion, you know already that there's a poor outcome, or else you wouldn't be asked for the opinion in the first place. So unfortunately, that prejudges it a little bit. But it's like reading a novel. Some people go to the end and see what happened, and then work their way back. And I think people do that in medical legal opinions. It's human nature to say, well, really, what really happened and what was the outcome of this, and then work the way back, which I think is actually a mistake, because already by knowing the outcome absolutely, you're then forming your opinion based on the outcome rather than actually what came in the middle, the management and everything else. And I draw the analogy with a book, and most of us don't go to the end of a book, but that would be the analogy I would draw. And I think that's one of the errors that some people make, is that they want to know the end, and then they fit the middle piece, the management piece, into the end.
Well, that's some really great advice to anybody who does medical legal work or thinking about getting into it. I mean, you've just heard it there from a very seasoned expert. And I really appreciate what you just said there about the time to make decisions. And I've never kind of put that together, what a luxury it is as an expert to pick and review and look up the standards and look at current issues and to know the full medical history. I was speaking a few years ago at a legal conference, a medical legal conference, and one of the lawyers there asked me, in a messy situation, who the hell's in charge? And I was like, sometimes everybody is walking into a crisis situation, and there might only be one person in the room who knows very much at all about the patient, especially you OBs that are often called in to a situation that's been developing for many hours, but has just hit the point of no return where there's intervention required. So I appreciate that perspective, and the respect for both medicine and law, which I try to maintain here. It's interesting for us to all have compassion for each other's side of the story.
Yeah. I think we do. I think the basically, I think we all must understand that in medicine and nursing, we're all trying to do the right thing, the best thing. We don't get out of bed in the morning thinking, oh, today I'm not really that into it, so I don't think it can't happen. You can't do that. It's just not allowable in our world. I can't just take the day off, or I can't just think, well, I'm not really that into it today. So it's a very different world. And obstetrics it takes it even higher than that. You have to be on your best all the time. It's like you've sort of got to have your 5 cups of coffee rather than 2 in the morning, because you're going to be running and making decisions, and decisions just pop up. And to your point is, with obstetricians, and frankly, the book stops with us, literally. And if there's a bad outcome, invariably we're involved, because something's happened to have us involved as obstetricians. And it's kind of interesting, I find, that we walk in there and have to make a decision in a few minutes regarding something that may have been going on for hours or maybe even days before, which have gradually contributed to getting to that crisis point. But it's interesting that it's viewed, and by the patients also oftentimes, but also by the law firms oftentimes, that the clock starts really ticking just before we see the patient and then after we've seen the patient, rather than looking sort of back and seeing how a constellation of features have happened over days or hours, and then we've involved. But it's our job. It's our job. The book stops with us, so that's our job. And I'm very clear with students that if you can't take that pressure, you should not be in obstetrics. I mean, it's simple. I mean, I remember listening to a podcast. I was interested in medical league, and there was a lawyer in Florida who did medical legal work. And as you know, in Florida, oftentimes women can't find maternity providers because no one's doing, because they get sued every 3rd patient. And he said, well, if you can't take the heat, get out of the kitchen. That was actually on a podcast when he was talking about obstetrical lawsuits. And I thought, I didn't agree with him, but he was actually right. I mean, if you can't see yourself putting it with that pressure, then you're best not doing it, because it's a specialty that is, you've got to have a special mindset to do, especially when the higher risk of obstetrics. You just have to have a special mindset to do it. And I admire people who go into it. I always have done, and continue to do so. But obstetrics is a minefield, literally, from a medical legal perspective.
I agree. So what is it in you? What's the quality in you that's allowed you to take that heat and that pressure for so long?
I think probably I'm just fairly laid back, and really, and part of it's a learned behavior as well. I mean, the residency, I would say to the residents oftentimes, I said it's 10% skill and 90% nerve. That's probably overplaying it, but it doesn't matter how skilled you are if you haven't got the nerve to stand there in a situation where things are going to pot, literally, and be able to make a decision and guide those around you who are looking to you for direction. We're all a team. So we work in teams as nurses. We're all part of a team. But ultimately, if we're being really honest, is that they ultimately look to you to direct that team. And if you want to make decisions, therapeutic decisions by committee, you're probably best going into internal medicine.
Right.
Excellent
That's
people,
good.
but very thoughtful. You're going to obstetrics. It's not by committee. It's evidence based, but it's not by committee.
No, that's right. And I'll tell you, as part of a care team, as the nurse in obstetrics for many years, when a really competent obstetrician walks in the room who is comfortable with that role and that responsibility, the whole place takes a deep breath, and we're just grateful that you showed up and you have a sense that things are going to be okay, or as good as they can be for the situation you've been presented with.
And let me be very clear. It doesn't mean that our insides are not in turmoil, even though we stand there looking quite calm and making decisions. The inner turmoil, and I still have it even now. I mean, you never show it. It's something you do not show, because at that point in time, the patient is looking to you because you've been built up to being the ultimate decision maker, and they're looking. The lady who's in labor and her partner are looking to you to be the voice of reason, the voice of decision, who's going to share the decision with oftentimes in a very short order. So one has to be extremely always kind, compassionate, but be able to put the facts in a very short period of time to explain why you're suggesting this. Because people, women want to know what's going to happen to their bodies, and they have every right to do that. But sometimes time is short, so one has to be able to capture that in a very short period of time to explain what you think is the best thing for her and her baby at that point in time, and do it in a way that's not autocratic. There is first people's rights, but in a way that says, this is the reason why I'm concerned, and this is why I'm offering to do this, and this is the speed at which I need to do this. And there's a skill to that without being alarmist. It's very easy to be alarmist, and then the patient is unsure, that you're not sure, and that takes longer to get to the end point.
I appreciate that, because certainly there is a skill to that. And, I've seen it change, and I'm sure you have over the past 30 years, where women rarely walk in and say, whatever you think, doctor. There's a plan.
Yeah.
And there's a lot of education, and there's a lot of thoughtfulness that goes into it. Let's focus the conversation back a little bit on the medical legal world.
Right.
Although this is a great conversation, I could talk it for days. But talk a little bit about your experience of being an expert, and particularly the experience of being cross-examined during trial as an expert witness.
I can remember the first time this happened to me, and I was quite young, and I went in and I thought, I know a lot. And it was a real wake-up call, because as physicians, surgeons, obstetricians, we are very comfortable in our own environment. And this is a completely different environment over which you have really little control. The only thing you have control over is what you say. And it was very interesting that, and it's interesting because we as people want to please. And the first time I went to court and I was cross-examined, the people who I was given expert witness for were kind of kind. The lawyers were very kind to me and smiling, and it was all very nice. And I thought, well, this isn't too bad. So then I get cross-examined the other way, and they also were smiling, but obviously not your friend. And the questions they ask is very interesting, because in the legal profession, it became very obvious to me that they obviously live on facts. Understandable, they have to live on facts, but they also live on words and expression. And how you word something is incredibly important. And I find that, slightly getting off the point, is that as an expert, when being cross-examined, you never speculate unless asked to speculate, because as soon as you start to speculate, and it's easy to do it, you're being led by someone who's smiling at you and seems quite a reasonable person, and you think, okay, I'll play along with this, and then you start to speculate. So then you're getting away without invite. If someone actually invites you to do it, that would be fine. But when they don't invite you to do it and you speculate, even though the way you're speculating might actually be quite true, your variance is now away from the facts for which you're there to discuss. And that's how I think expert witnesses get themselves into deep trouble, because then the value of what they're saying is cheapened in front of the judge, because you're umming and ahhing and trying to backtrack away from something that you've speculated on, of which you have no basis. You have no factual basis. There's no research you can back it up with. But it's human nature to do that without invite. So I always thought it was an eye opener. It was a whole day, morning and afternoon, and I can remember it. And I went out, and I thought inwardly after. I thought, I thought, first of all, you feel absolutely exhausted, absolutely mentally exhausted, because you've got to keep saying to yourself, you stick to the facts and stick to the question. And if someone asks you to speculate, only do it in that situation. The rest of the time, you answer the question straightforward and add nothing to it. So if someone asks you a question, if the answer is yes, then you say yes. You don't say yes and, or no and. And what you have to say, I find, is be sure that you can actually back it up as well. Because it's very interesting that I will rifle through a fetal heart rate tracing, which may be hours long, days long sometimes, and I'll rifle through it, and I'll get to the point. I'll look through it because I'm used to looking at them very quickly. Get to a point where, to me, this is questionable, not questionable. Everything before that isn't. But they'll take you back to something. Oftentimes on a fetal heart trace, and just using obstetrics as an example, where yes, it's not normal, but in the context of everything else, it is. And so it has to be a preparedness for that, but the preparedness to answer the question is really important. And I think before, when you go there, it's human nature, you want to please, so you want to give the answer they're asking for. Well, no, actually, what they may be asking for maybe not be the answer that the facts support. And once you've gone down that path, it's a slippery path, and there is no end to that path going downwards, apart from, extreme embarrassment, stuttering and muttering in front of a judge who's looking at you thinking, like, what is wrong? I mean, does this person know what they're talking about? So I've learned very quickly to sort of condense my answers down quite quickly. So the second time I went to court, it was again facts answered. The answer's facts, and that's it. And if you want to ask another question, fine, but always beware of the cross-examination who's smiling at you, because they're not your friend. However nice a person he may be outside the courtroom, within the courtroom they are there for a certain purpose.
Right, they're there to do a job, and it's not to help you in any way. Yeah. I'm glad to hear that you were exhausted after that first time, because my first time in court was in a small courtroom in Ontario. It was again all day, and I'd never even been in a courtroom before, but that's the day I discovered a lovely little service called Dial a Bottle that would deliver straight to your hotel room. And it got a little bit easy after that, but it never got easy. It's a real, I read books every once in a while that says, learn how to enjoy being an expert witness. I'm like, I don't know that I'm going to get to the point where I enjoy cross-examination. But why, I did two questions around that. Why, I mean, this is a tough gig. I mean, you've got a lot going on anyway from your work that you're doing, but adding the expert witness work to it is a whole nother level of, just work and time and energy and stressors. So why do you do it?
Very great question. I actually enjoy it. Do I enjoy the fact that someone else is being their work and their practice has been questioned? No. Do I enjoy the fact that oftentimes, because I've been called to give an opinion, that somebody has suffered or a baby has suffered? No. But I'm fascinated by the intellectual aspect of it, the decency of being able to, what's the word I'm looking for? To be able to give a factual account of what's happened. And I'm fascinated by the law, actually. Always have been. And so that's the reason why I do it. It's a lot of work, but I find it quite rewarding. And I go back to my point about the advocacy part of it. I don't find it satisfactory necessarily if I'm part of the team that, it's not a win-lose, unfortunately, because someone's already lost. If I'm in court, somebody's already lost something in their lives. But there is some satisfaction that you've given an opinion that has been taken and has been utilized positively to get to a certain outcome. And whether the outcome is a settlement, it doesn't matter. But I find it intellectually very simple, and I find the law fascinating. I find the way that lawyers look at medicine absolutely fascinating. And to take that one step forward, even though there's part of me, especially when you've got a suit against you actually hate the law, actually, I think it has actually added a significant amount to the way that we inwardly look at the way we practice. And there's a very fine line here, as I think, between your practice governed by, well, if I do this, am I going to get sued? Or what the law has done, medical, is made us think much more about safety, about patient safety, about the way we do things. And we like to think as physicians that we do that because we're going to do that. I think we're partly influenced by law, by the expectation, and perhaps the law basically sees medicine the way the general population sees medicine. And I don't necessarily think that the court of law is necessarily where we should be held into account. No. But I think what it's done, it has made us look at patient safety in a different way. We always looked at patient safety as being important, but I think it's now it's brought upon almost a whole subspecialty of quality, safety, and improvement that would have happened anyway, but I think it's been promoted by medical legal activity.
So to expand on that a little bit, could you give a couple of descriptions or name some ways in which your work in the medical legal world has changed your personal practice and or changed the way you teach medical students?
Yes, it's interesting. I mean, the first thing that it's always taught is the way you document something. And documenting is two things. I think it's a record of what you do, but it's also a reflection on what you've done as well. And I think because of that, it's taught me that inward reflection. I think what it's taught me, practically speaking, is that I'm not always right. That as physicians, and I was brought up in a long time ago in medicine where if I made a decision as a consultant, that was right. That was the way it was. That there is no question that this is right or wrong. This is the right decision. And that may be based on many things and usually not evidence, frankly. What it's made us do more, and myself also, is look at the evidence behind the way I do things. And do I have evidence to do this? Do I have evidence behind this? And I think one example would be now interested with your wonderful webinar regarding fetal heart rate tracing and fetal heart rate interpretation. And I think it's very interesting. I'm just slightly aside here that there's an interesting study in Australia where they put forward fetal heart rate traces, and they gave it to a whole different people in training, nurses, the training staff, and the senior consultants, without giving them the end result. Asked them what they thought the outcome of this was, and the worst at it were the most senior. Fascinating. And so it's just made me much more reflective about the way to think. And surgically, it has, I think what surgically it has done, and I live in the world, for instance, I live in the world of pelvic organ prolapse, where obviously the law was very involved with the use of mesh, and I might be slightly getting off point here, but there is a point to this, is that these meshes were being put in totally willy-nilly by people who had no place putting meshes in for prolapse. No place. They did a weekend course and that was it, which falls unfortunately on the responsibility, I think, of the companies to some degree. Anyway, the point I'm trying to make is that we put the meshes in, there were suits regarding the actual mesh, but actually the techniques we used to put the mesh in, we still use. we just don't use the mesh anymore. So it's interesting how, the law has brought about us recognizing some of the things that we do, which are absolutely terrible. But also we still use some of that. We have actually used those techniques ongoing as a result of the lawsuit actually happening with mesh. I don't know if that makes any sense or not, but it makes sense.
Well, just to clarify, that was because I was very involved with a class action lawsuit involving mesh, in the pharmaceutical companies, and saw firsthand some of the horrendous outcomes associated with it, with thousands of women. But just to clarify what you just said, so you're still using the technique, but in the the problematic cases, was it the technique that caused injury, or was it the use of mesh that was the problem?
Well, I think that it's a two-answer question. There's two answers to that. The first one is I think it was a technique, because let's be perfectly frank now. For the mesh, practitioners were putting very large needles through blind spaces, through structures they'd never palpated before in their lives. So there's that anatomical aspect to it, was where was that needle? Because once that needle disappeared, they think they know where it was. And then, of course, the problem was then the mesh and the mesh kits, it was one size. So it's one size fits all, which never works in medicine. It doesn't work in anything, but it definitely doesn't work in medicine. So there's the two issues there. One was anatomically, many of the people, I live in the pelvic floor, so I really use very little mesh for prolapse, absolutely very little mesh for prolapse. But it was necessary. So had it been allowed that we could use it in the certain circumstances where it was required, that would be perfect, because we knew our way around the pelvic floor and where we were putting these things. Mm-hmm. There were other, unfortunately, people didn't know the anatomy. So therefore, the mesh ended up in places it shouldn't have ended up in. And it was being used as a primary operation when it was not indicated as a primary operation. Result upon that, it was a perfect storm. So people practitioners were putting it through anatomical space they didn't know. So there was nerve injury as a result of that, because they stuck it through places they shouldn't have been. And then there was a foreign product there that they'd never handled before in their lives. They didn't know how much they should have been using it, because they just gave them one piece. It's a cookie cutter sort of approach. And then this mesh it eroded. So the problems were, it was either stuck through the wrong place anatomically, first of all, or it eroded through the incisions that they placed it through, which caused all kinds of harm. And it's interesting how, the class action lawsuit was ongoing. It's ongoing, basically, in all parts of the world. And the problem is, I find, and this is where there's a problem, is it has taken away the opportunity to use that material in certain patients, where the studies show actually it is of benefit, but not as a general usage for all comers. And that's where the sad story is behind mesh. The sad story is, one, that women have been injured significantly, and the second story is mesh in certain patients will be completely appropriate, but we can't use it anymore, or we don't use it anymore. So the mesh story is an interesting story.
That is an interesting story, and that's a perspective I've never heard from it. Because certainly when you look at the injuries, it's easy to say this should never, ever, ever happen, and this should never be used again. And even the history of whether or not that mesh was approved for pelvic floor insertion.
It wasn't.
Yeah, no,
it wasn't.
I recall
Literally,
that.
It was because of a idiosyncrasy in the FDA approval process. Yes. How it progressed itself down the line without ever actually being called into task, never having been forced to do any safety studies. There was some short-term efficacy studies, but no safety studies. There is a lot of people who should be inwardly looking at themselves with the whole mesh issue, and not just the doc who put it in.
I agree. I agree. There's a long history there, a long story to tell that I think most of the public hasn't heard yet and may never hear.
Yeah.
So how do you think that your experience and knowledge and exposure to medical malpractice cases, and how do you hope, well, I guess more specifically, how do you hope your work in medical malpractice might change or improve healthcare outcomes?
I think I've alluded to this. I think it's because it's made us look inwardly much more at safety, without doubt. And again, as I think intrinsically, we were doing it as a medical provider group, nurses, docs, and the like. But I think it's really now pushed it onto the forefront, and that ongoing learning that was expected of us. And I'll use back to the fetal heart rate tracing again, is that it's forced correctly the ongoing. It's not like you've got to a certain point and you've learned fetal heart rate tracing, you can't get any better at it. No. What it's done is showed us that, in fact, we should be looking more closely at the way we interpret this. We should be doing more continuing education regarding it as we come to recognize an imperfect test, what we can gain from it, what we can't. And fetal heart rate tracing is an imperfect test. Let's be honest now. I mean, it's interpreted, and we can, but to aid people in interpreting it, there are systems that we need in place, which are now in place, which were never in place before. And I think the instigator behind it undoubtedly has been medical legal suits.
Mm-hmm. So it's got a role to play for sure.
Yes, absolutely.
Go ahead.
Absolutely. I don't literally being sued is probably the depths of your practice. Literally, you're at the lowest point. Absolutely. It has actually a place to play. And do I always agree with lawsuits when I give opinions? No. I mean, sometimes I'll just say I don't see what you're seeing, and you're putting 2 to 2 and 2 together and getting 6. But it has made us think carefully about the way we practice and the safety of the practice. I think that's where it's had immense importance.
Well said. So you've seen medical malpractice from the perspective of being a defendant and an expert and reviewing lawsuits and reviewing other people's medical legal issues and concerns. What would you change about the system if you were in charge of the world?
I would advocate for no-fault insurance. I go back to we do not get out of bed in the morning in the idea that we're going to do harm that day. I recognize that lawsuits are necessary, and they're socially necessary in North America more so than anywhere else, but everywhere, and especially in obstetrics. And here's why I think, and again, maybe slightly getting off topic, is that patients, if you have a baby that's impaired and is going to live for 20 years and unfortunately requires all manner of social support, physical support, there is no social network. There's no social net that's going to pay for that. You get a little bit here and a little bit there and a little bit everywhere else. So the only recourse is the combative arena of medical legal. There should be, in those situations where that has occurred, whether there's, and I hate to use the word, but I'll use it in parentheses, fault that can be apportioned. Ultimately, the end point is that your society, and let's put it in the societal way, is wanting to make sure that these children are cared for in the best way possible, which takes money. And so, yeah, in an ideal world, we would not have the combative medical legal system. We would have a independent body system that would look at everything, and physicians would be accepting of this as well, where these independent would say, yes, in this situation, it's almost like a judgment, I suppose, in a way, and say, yes, this is what it's going to take reasonably to care for this child to expected age expectancy of 20 years, for instance. Now, I mean, will that ever happen? No, sadly, but it would take away from that combative, and it is combative, let's be honest now, that combative medical legal arena. And it's not, and I'm not just talking this from a physician point of view, I think from the patient point of view, because oftentimes and let's say there's a poor outcome for a baby, oftentimes the mother and the family will sit in that courtroom for 7 days or 10 days and basically replay probably the worst time of their lives will be replayed completely in front of them again. And so I can't even come to think of the emotions that they must go through in that situation. So that's in the ideal world, to be honest with you. And I think the second layer to that would be there'd be an independent body which would say, this is a nuisance suit. It should be stopped right now before there's any more expense, either from the plaintiff side or from the CMPA or whichever insurance body you have. I think that would be acceptable. I think that would be a reasonable compromise, because the first option I gave you, I don't think is reasonable. You said in an ideal world, and I gave you an ideal world situation. But I think there should be an independent judiciary, if you will, which is whereby you say, there's nothing to be answered here. This is unfortunate. And then obviously you have to think about, if there has been a baby that's been impaired, how are we going to care for that baby in the future? I mean, I'm just thinking about ideas that have rolled around my head as I've done medical legal work. That's what I always feel would be fair, and then everybody would get their say, and it wouldn't be quite as combative all the time, because it does get pretty combative. There's no doubt about it.
Well, that's a good answer and an interesting answer. You're not the first person who's approached that idea of the no-fault insurance. How would you, I'm just kind of thinking like a lawyer for a minute, and there's objections to that, but I won't go there. But I guess one thing I would ask, if this were to ever come into play, a newborn who's injured, the story unfolds over years and years and years, and you don't know until you know how they're going to do in school, if they will get through school, if they will be employable, what kind of behavioral issues or problems they'll have. How would you, or do you have a suggestion, or maybe this is too big of a question, would you deal with the unknown aspect of sorting out the amount of money a child might need to get them through their lifetime?
Good question, and obviously I hadn't thought of all the caveats, as you can tell. But I think there would be ongoing assessment where that's concerned. I mean, there's going to be a basic need that is apparent at the time of the suit. Or there would not be a suit in the first place unless there was something very significant with the babe to start off with, or the child. And so if the baby is significantly impaired, I think you could do algorithms for this, and I'm sure there's very clever people who could do this. Is that if the lawsuit is launched and the baby is 1 year old, you know full well that baby and that child unfortunately has significant cognitive muscular abnormalities which are going to impair that poor child's life, and so it's going to take a lot of money. If it comes back to you 8 years later when learning at school isn't as good and they are on the bottom half of the not where they're expecting to be, they're not progressing what they're supposed to be, whether it be in learning language or whatever, it's going to take less money. If I'm being very frank, it's going to take less money. They're not perhaps going to need a lift in their house or a special car or a special lift. So I think the Kimin algorithm could be thought of. I think we need some clever economic person to be able to do that. But I think it would be an interesting exercise, and maybe something could come out of it, maybe not. I'd love to be involved in something like that.
It's an interesting perspective, and and it's one that gets battered around in many, many circles. Yeah. It hasn't ever truly seen the light of day, not in our country anyway. But
we're not going to see it for some time, obviously.
Yeah, pros and cons to everything.
Yes, indeed.
So I know you're a very busy guy and you want to be respectful of your time, and we want to come back to just record a little bit more of a podcast about you personally.
Oh, really? Okay.
But I like to ask this question of every podcast guest that we have, because our audience includes lawyers, doctors, nurses, midwives, and the general public. Would you answer this question for each one of those audiences? And we'll start with doctors, obstetricians, perhaps OBGYNs specifically. In your view, what is the most important thing that you would like fellow physicians to know about lawsuits in the obstetrics gynecology clinical area?
The first thing is, as I've said already, they are part of our lives, and anticipate that they're going to be part of our lives. Secondly is, we know that, and this is a bit motherhood and apple pie, is that nothing you do has been volitional. So regardless of how terrible you feel, and believe you me, physicians may not appear that way, but we feel terrible when it happens, is that you're not at fault. That, you know, first of all, you're not alone. You're not at fault. And that in some ways, once you've actually gone through the rigors of the lawsuit, which you know, have actually killed some people's careers, you know, you can use it, try and use it positively. If you can ever find something positive out of it, to improve the way you view things and the way you practice and the way you involve yourself in patient safety. So it's horrible as it might seem, you got to find something positive out of it, because otherwise the 3, 4, 5 years that these lawsuits take, and sometimes longer, really will keep you up at night and basically maybe negatively affect the way you practice.
That's the truth for anybody who's been through this. So good advice. I'm going to ask that you break that down into, for nurses as well. What would you like nurses who you work with all day, every day, to, what's the most important thing you'd like them to know about OBGYN lawsuits? Because nurses and GPs and obstetricians are very often all pulled into the same lawsuit.
Yeah. That for nurses as well, they are part of the, I mean, being part of a lawsuit basically is recognition of how important the nurses are in the team who look after patients. You know, I don't know whether it's viewed that same way by the law, but they actually are an important part of this. Now, that's great 99% of the time, but you have to remember that from the nurse's perspective, is you're part of a team. You're not alone in this, even though it might feel very lonely when it happens. You're actually part of a team, and each one of you were contributing to that patient's well-being, and you did the very best to make sure that this outcome didn't occur. But I think the message is it recognizes that you're part of the team when things are good, but also, unfortunately, when things are bad as well.
That's probably the team you don't want to be on in that moment anyway. Like no gracias to that, right?
Yeah, and you know, and the other thing from a nurse's perspective is, when you get this, remember that there's usually 10 times as many nurses named as there are physicians, because invariably, if it's an obstetrical lawsuit, it's gone through that many different nurses as well. So your part in this, if it's a part, is usually relatively small, you know, because oftentimes you've been named as one of 20 nurses who may have just been in the room to relieve for 30 seconds or something.
Yeah, good advice. So take a deep breath and look at the chart and figure out what went on.
Yeah.
What would you like the lawyers to know about OBGYN lawsuits?
I'd like lawyers to know that really, however, sometimes it may appear that what we did was, in hindsight, was so abjectly wrong in their opinion, that in fact, we're not there, we're well trained. We're not there to harm people. We are there to do our best in a situation, and I'm going to say it's a difficult situation. I think it is a difficult situation. That I think it's that sometimes they should just take a step back and realize that when a physician and nurse gets sued, it can be life-shattering for some of them. Two, as I've said before, that they have got days, months to look at something that may have taken, especially in obstetrics, and I can talk about the surgical side as well, but just obstetrics, we may have had 2 minutes to think about. And just occasionally, I know it's not perhaps what should be said, have some compassion in that situation, because you're still going to get to the end result. You're still going to have exactly the same factual outcome. You don't have to make it into this incredibly combative situation where I've seen in court, I've seen physicians and nurses have been driven into the ground by cross-examination when your point has been made. You do not need to belabor the point. You've already made the point. Hammering that person over and over again really gains nothing. And I've seen this happen. And where they've asked the great question, they've got exactly the answer they want, but they want the cherry on the top, and there's no point. Literally, there's no point. You've made the point. You've made a great case. Why continue on down that line? Because I think sometimes, to me, and I'm not the judge, and obviously a judge is a third-party person who is looking at, I would think, because I've sort of sat there sometimes and looked at the judge, and they've looked sort of quizzically, like, what they're talking about. They want facts in very short order given to them so they can assimilate those facts and come up with a judgment. So I'm not being critical of the law, not at all. It's just an observation I've made. But I think the lawyers just need to know that this is, not only has this been a life-changing situation for the patient and potentially the baby, but it is also life-changing for those that are sued, because they may only happen to them once or twice. I mean, that's just the way that obstetrics is. I think that's basically what I need. And don't ask, the other thing is, don't, in your instructions, make it sound like you're asking an expert witness to be an advocate. They're not. They're just there to give you the facts. Now, their summation of the facts may not be what you want, but I think that's as positive a response as having something where it's advocacy that maybe would not hold up when someone has to be cross-examined.
That's good advice. I did a presentation on this a few years ago about that word advocacy and what a different meaning it has in the legal world than it does in the medical world.
Yes.
Very different, very different. So last question for you. Answer that same question for the general public. What would you like women in labor and their families, or women undergoing gynecological surgery, to know about lawsuits in that clinical area? I think patients sort of need to know, but first of all, they need to know the negative effect that it affects on everybody in the lawsuit. I mean, however much they can't see beyond themselves, which is totally understandable, do not get me wrong there. But they also need to know that it's an interpretation of fact which may be interpretation of fact by different people who weren't actually there at the time. So they're only working on the basis of what they can see, what they can read, and what information they have available to them. In gynecological lawsuits, it's a bit different. I mean, if you have basically gynecological, like any surgical lawsuit, lawsuits are usually because the patient has not had a satisfactory outcome that they would like, and or they've had some inadvertent injury occur whilst getting to a satisfactory outcome or an unsatisfactory outcome, whichever you look at it. And I always think that patients should know that, yes, this is
they're right to do this. There's right to call us into absolutely. I'm not questioning that in the slightest. What I do question sometimes is the use of lawsuits in some way to, especially even from a surgical perspective, is some way to apportion blame or apportion, my life has been badly affected, therefore, and you see this sometimes, your life therefore should be badly affected. And the message should be, again, is that we don't go to work to do harm, but harm or complication is an inherent part of medical practice, and risk is part of medical practice. That's just inherently part of it. And I don't think people quite understand that quite so much. They think that because we have such great technology now, and we have so many different ways of doing things and looking at things and so many different imagery things, that, everything's going to be perfect. No, that's not medicine. And I think the patients need to understand that.
Interesting. No, it's like the meeting of high expectations with an imperfect science, or that
Yes.
remains perfect. Yes, exactly.
And obstetrics is the prime example of that.
Yes, I understand. All right. Well, I just want to say thank you so much. I could sit here and talk to you all day if we both had nothing else to do, but yeah. I know we both do, and you in particular. I can see you have a busy day ahead. So I just want to say thank you so very much, Dr. Birch, for being with us. It's been fascinating and insightful. I've loved your opinion on multiple things and your story. If you haven't listened to it, don't miss the shorter podcast by Dr. Birch, where we're going to get a little bit more into the details of him as a person. You've heard a lot about his profession and his work. But for now, let's just sign off. And thank you so much. It's been a pleasure.
Thank you very much for asking.